Thank you, Mr. Secretary. Under Committee Rule 9, we will now question the witness under the 5-minute rule. I ask members to keep your questions succinct so the witness has time to answer. I recognize myself for 5 minutes of questioning. Mr. Secretary, this committee's efforts helped lead to the passage of the historic No Surprises Act. However, the law's independent dispute resolution process has been mired in litigation, delays, and faulty implementation. Data shows that 77% of disputes are ruled in favor of providers, and the Brookings Institute now anticipates that the IDR process will raise costs and premiums, contrary to the law's goals. What is HHS doing to improve the operations of the IDR process under No Surprises Act? And are you concerned that the law's current implementation will raise health care costs for employers and employees?
Madam Chair, thank you for the question. And you're right, because there was a mad rush to try to make this independent dispute resolution process work, I think we saw that the gates got overcrowded. And as a result, we saw that there were delays. The arbitrators were wondering if they were going to get paid. There were a limited number of arbitrators. We think most of that has now sort of settled. We're now beginning to see that the cases that are coming through are eligible to be processed through this dispute resolution process. Initially, in that first year, we saw scores of these cases that were ineligible, and of course they took time. And since an arbitrator only gets paid for a case that's actually adjudicated and completed, arbitrators were getting very unhappy because they were having to adjudicate claims that didn't go anywhere.
But we're very concerned about the increased costs, so what are you going to do about that?
So by having been able to essentially scrub the system so that it now is much more efficient, so that the claims that come in will have an opportunity to go before an arbitrator, we're beginning to see them run a little faster. Because the courts have given us more guidance on how they wish to see us interpret the law, it should go faster as well.
Thank you. I'm concerned by regulatory overreach by HHS over self-insured health plans. The recent Notice of Benefit and Payment Parameters final rule and the Section 1557 Non-Discrimination in Health Programs and Activities final rule saddles self-insured health plans with new Obamacare regulations. Under current law, self-funded plans are not subject to Section 1557 or regulated by the Department of Labor. Will you confirm that it is HHS policy that self-insured health plans are not subject to HHS regulation, and will you commit to abandoning any unlawful HHS efforts to regulate self-insured health plans?
Madam Chair, let me make sure I give you accurate information because we have seen an evolution there. I don't want to give you an answer that's not complete. So if it's okay, let me follow up with you to give you the precise answer.
Okay, but we'd like that answer right away. No delays, please.
I commit to giving you that.
All right. I'd like to ask about parental rights in the Head Start program. The Head Start statute goes out of its way to describe parent and family engagement in Head Start services. In the department's recent Head Start workforce proposed rule, there's even language that claims to ensure, quote, programs are consulting and engaging with current parents and families to be involved in the methods the program uses, unquote. However, the proposed rule strikes from current regulations the requirement that parental consent be obtained for mental health consultation. What is the Office of Head Start trying to hide? Does HHS intend to complete mental health consultations on children without parental consent?
Madam Chair, there's nothing that's being hidden. What we're trying to make sure we do is provide the services that are important for any child in the Head Start program. We want to make sure that whether it is ensuring the physical safety of a child or also addressing any mental health concerns. We can try to follow up with you if you have particular concerns with some of the language, but I can guarantee that what's going on in this rule on Head Start, proposed rule, is the best interest of the child.
Well, we will see, but we think that needs to be clarified and that you are not giving mental health consultations on children without parental consent. With that, I yield, and I recognize Mr. Courtney for 5 minutes.
Thank you, Madam.
The law reduces barriers for treating persons with substance abuse disorder by aligning the privacy laws governing the records with HIPAA, the law which governs all other health privacy records. This has allowed for medical professionals to access vital information they need to properly coordinate the care. In 2018, Congress passed a separate law in honor of Jesse Grubb's life, just called Jesse's Law. This requires HHS to develop best practices standards for hospitals and doctors to display a patient's history of opioid disorder when the patient provides that information. With the implementation of the Legacy Act, it's now time to fully implement Jesse's Law. So the department has finalized a rule on confidentiality of substance use disorder patient records. When will it be releasing best practices for displaying opiate use disorder in patient records?
Senator, first, thank you for the work you've done, because I don't think people recognize that in many cases, because of this, I don't want to call it an excuse, because of the difficulties with privacy laws, HIPAA privacy laws, a lot of essential information about a patient wasn't getting to the providers, and they were making the wrong decisions, especially when it related to drug addiction. And so the work that you and your colleagues have done has really helped.
Well, Senator Capito and I worked on it, but we know the family very well. It was so horrifying. This young lady had problems, and something stemmed from when she was in college, but then she was trying to get herself clean. She started running and being competitive.
Yep.
And she and her parents, who an attorney and her mother's a educator, both went with her to the hospital and says, please identify and mark my record showing it, and they forgot to do it.
Yep. And so what we're doing is we're trying to tackle that HIPAA privacy hurdle so that it doesn't become the reason the information isn't fully there. But you can understand how important it is to maintain privacy.
Oh, no, we know that. But now that we've done everything, we've went through every hoop possible.
Yep.
When will you all be doing? When can we expect it to finally be implemented?
We are now working with providers. We've developed a training module so that they understand how this can work, how they can be consistent with privacy laws, yet still include the information. So a lot of it's going to be, and we can use your help, because we need providers to start understanding what the new rules are. They're going to say to you, oh, no, we can't do that because of HIPAA privacy. We want them to understand, oh, no.
Well, I think the law is very clear. Basically, it says that the patient himself and the guardians have to have permission and give you permission to do it.
Yeah.
So we thought we crossed every hurdle, crossed every T, dotted every I. Yep. It's just time to implement it. So I would implore you to
we're doing it.
Get your staff moving on this one here. We've waited a long time for it.
And Senator, I'm just pointing out, we need the help of the providers to make sure that they're getting their personnel to understand the new rules.
Okay.
Yeah.
Well, I think the quicker you put them out, the quicker they'll understand them.
Absolutely.
The Health Resource and Service Administration administers grants and programs that are critical to rural health centers and clinics and hospitals. Your budget requests a $2 billion increase to this agency to carry out these programs. However, many areas of West Virginia remain unable to access these resources. West Virginia is the only state that lies completely within the Appalachian Mountain region. The United States Department of Agricultural, Economic Research Services recognize the unique topography. We're the most rugged mountainous state, east of the Mississippi. And a recent report on what we call rugged terrain. That's all been identified and how we've been classified. The report found that almost 81% of West Virginians live in a rugged area. That's compared to just 11.7% of the entire United States population. The fiscal year 2024 bill included language for HRSA to review this report to update their rural definition to better capture the uniqueness of Appalachia. Can you provide an update on this review and a timeline for when we're going to see some results so they can qualify for the needed funds they need for rural health care?
So we're not waiting. As you know, Senator, we are moving forward with a new classification, this new classification for hospitals that don't meet the critical access care definition, so that a lot of those facilities that are teetering don't go under, so they can get some additional funding. I was mentioning to Senator Capito some of the work we're doing to make further investments in behavioral health, especially in substance use. But we are absolutely prepared to work with you as you all give us some guidance about how to get into these communities that are very rural to make sure we're being as constructive as possible. We will work with the states as much as we can because they understand better what their state needs in terms of the rural health facilities. But we're trying to make sure that these new changes that you helped us put forward will help some of the states that have large rural communities address the concerns of individuals a lot faster.
Well, sir, I thank you for your service. I just want to say again, on Jesse's Law, that has been a long time in coming, okay? And the families have just, they're hanging on needles and pins, just waiting for it to be completed. They want to save lives, and they don't want anyone to go through what they've gone through. And on the rural classification, if you want to know why that divide is becoming bigger and bigger, rural areas have been left behind. The money has not gone appropriately for the challenges they have, and that's so important.
Yeah.
Thank you, sir.
Thank you.
Senator Hyde-Smith.
Thank you, Madam Chairman. Good to see you, Mr. Secretary. Thank you for being here. In 2003, Congress established the Rural Community Hospital Demonstration Program to test an alternative payment model for rural hospitals that were facing certain financial constraints with the Medicare's Inpatient Prospective Payment Program, the IPPS. And Congress has extended the program several times, most recently in the Consolidated Appropriations Act of 2021. But Mississippi ranks among the states with the highest rate of hospital at-risk closings. This demonstration program could serve as a means to keep their rural hospital doors open to serve their communities in need of high-quality health care. However, CMS has not solicited applications since 2017, despite, as I understand it, there being a handful of open spots in the program. Do you believe this program has been helpful to rural hospitals facing closure, and we should extend the program when the time comes?
Senator, thank you for the question. The rural emergency hospital designation extended a lifeline to some of these facilities. It is absolutely essential that we give hospitals that are willing to stay open a chance to survive if the older version definition of how they could get reimbursed isn't working for them. So we look forward to working with you because we've got to figure out a way to keep some of these facilities open and operating.
Do you know about how many spots are currently open right now in the program?
I don't have that with me, but I can make sure my team follows up with you.
No problem. And can you commit to working with me to solicit applications for the program and find ways to help us keep these hospitals open?
Absolutely.
I talked to administrators this morning that have been in my office, and we are constantly battling this in Mississippi. You know, we're just putting out one fire after the other. Mississippi has consistently seen some of the poorest maternal health outcomes in the nation, made worse by high rates of chronic disease and limited access to specialty care for many mothers. And we've also led the nation in infant mortality, something that we're not proud of at all and very concerned about, but it's driven largely by a very high preterm birth rate stemming from lack of prenatal care. Access to maternity care in rural areas is a major challenge, and we are seeing a rapid expansion of OB deserts, that we refer to them as, across Mississippi. In some areas of my state, women are having to drive more than an hour for any kind of obstetric care. How can we work with you to improve outcomes for our mothers and babies in Mississippi?
Senator, because everything you've said I agree with regard to maternal health, and especially how it's impacting our Black and Native American communities. The most important thing is early access. And as you've mentioned, sometimes, especially because a state like Mississippi has a lot of rural communities, it's tough to have access. And so that's why it is so important to not allow any existing health facility to go under in rural America, because then the access becomes even more difficult. Telemedicine, telehealth is going to be very important for communities, families in rural America, because it means they can have access without having to do the physical travel. We'll continue to support that so long as Congress gives us the flexibilities to offer telehealth flexibilities. But the most important thing is access. And I will simply say here, many of the women who are having bad outcomes could have qualified for earlier care had they been eligible for Medicaid. And I think if we expand Medicaid in some of the states that haven't yet done it, about 1.5 million more Americans, many of them women who want to deliver a baby, would have access to early care and not wait until it's a difficult circumstance in the delivery.
Yeah, well, I appreciate your concern and your willingness to help toward this because it truly is crucial. Mississippi's a large state. We don't have many people, but we're a large state.
Yes.
And we're scattered. And it is truly a hardship on so many mothers to actually get to that care. We have a lot of babies born in cars, sad to say. My time is out. Thank you.
Chair Murray.
Well, thank you very much, Chair Baldwin. Secretary Becerra, good to see you. I appreciate you joining us today. HHS really is on the front lines of some of the most challenging issues that our families are facing. Opioids, mental health, childcare, so much more. It is crucial that we maintain strong investments in life-saving biomedical research, building a strong healthcare workforce and public health system, getting families affordable care close to home, and a lot more. Not to mention the constant attacks on reproductive care. Women in 21 states are now living under abortion bans, and Arizona is under a ban that dates back to before women even had the right to vote. Despite strong support for abortion access around the country, anti-abortion extremists are continuing to attack not only abortion care, but IVF and birth control. Everyone, I believe, deserves the freedom to control their own bodies, their own lives, and their own future, free from interference from politicians, which is why I strongly support President Biden's decision to once again remove Hyde from this year's budget. I look forward to continuing to work with you to protect reproductive health care every way we can in all 50 states. And I'm glad we have the opportunity today to talk about how we can provide the resources necessary to meet all the health care challenges before us and support families in my state and across the country. Programs like Childcare and Development Block Grant and Head Start are a lifeline for working parents who need affordable, high-quality childcare and early learning opportunities for their kids. They are an investment not just for our families, but in our workforce and in our economy. So I'm really glad that Senator Baldwin and I were able to send an increase of $1 billion to the President's desk to invest in childcare and early learning for FY24. Since 2015, I and many others have increased funding for these programs by more than 250%. But it is, as you know, a drop in the bucket when looking at the childcare crisis that exists in this country. We need to protect and strengthen the investments we've made to make sure families can find and afford childcare however possible. That means more annual funding, extending stabilization dollars, and hopefully passing my Childcare for Working Families Act. Can you tell us today about the current state of the childcare sector and why investments in programs like CDBG are critical now more than ever?
Senator, thank you. And again, thank you for championing childcare writ large and your success in getting additional funds for so many families desperately in need. Today, getting childcare is like having your infant go to college. The cost of childcare is essentially tuition in a major university. It makes it very difficult for parents, especially parents who have more than one child, to really sustain that. We also know that the quality of care can sometimes be questionable because the pay for some of these workers is so low. You can sometimes make more money flipping burgers than caring for children. We need to change that as well. The President's budget, thanks to the investments that many of you have made possible, will continue to move an effort. The President's proposal would make it possible for some families to qualify to have child care for $10 a day, which would ultimately save them each, those families, about $7,200 in a year in the cost of their child care when you total it up. That would be a proposal that would help so many of the families, some 16 million families would qualify for that support. And so it's so important to move forward, as you said, to continue to make the investments in childcare.
Thank you. I really appreciate that. We'll continue to focus on that. Mr. Secretary, this week is Black Maternal Health Week. It's an important time to talk about the devastating maternal mortality crisis here in the United States. The U.S. is now one of the most dangerous places in the world to give birth, and that really is astounding to me, despite most maternal deaths being preventable. It is clear our systems are failing mothers, especially Black, Hispanic, and Native mothers who experience the highest rate of maternal mortality. And extreme state abortion bans passed since the Dobbs decision have further eroded the access to maternal health because we don't have as many providers for maternal health care across our country. We were able to secure a $21 million increase for the Improving Maternal Health Initiative across HRSA, CDC, and NIH in our FY24 bill, and building on increases from 23, and I hope to continue that progress in this budget. Can you talk to us about what HHS is doing now to address this issue and about the additional investments in maternal health that you're actually proposing for next year?
And again, because of the efforts of you and others, we've been able to continue to increase the funding of maternal health. This budget, 2025 budget by the President, provides close to $400 million for maternal mortality and morbidity to address that, because as you mentioned, in too many cases, a Black woman is 2 or 3 times more likely to die at childbirth than a white woman. I think I misspoke and said $8 billion. It's actually $2 million in this federal budget by the President is dedicated to maternal health. We are now, as I mentioned earlier before you got here, Senator, making available care for a woman who qualifies for Medicaid and for her baby, rather than just for 60 days, she now qualifies for 365 days of care, and so does her baby. We're doing a lot. Doulas are being made available to families. We're trying to do what we can up front before the delivery, so the woman gets good care before delivery, gets good care during delivery, and good care after delivery.
Okay, very good. And finally, on youth homelessness prevention, I am laser focused on making sure the federal government is doing everything we can to support young people who are experiencing homelessness and doing more to prevent it. I was very proud to champion new funding in our 24 bill for a demonstration program that will provide grants to state, local, and tribal governments and local organizations to help prevent youth homelessness. What is HHS doing to address and prevent youth homelessness?
Senator, thanks for that work that you're doing. We are working with states. I'm the chair of our Interagency Council on Homelessness, working with HUD and other agencies to make sure that we're tackling homelessness with the support of the local governments who actually have the day-to-day responsibility for it. I will tell you this, we are focused on getting families and children first and foremost off the streets. We're trying to make sure foster kids don't fall into homelessness once they age out of the foster care system. And so we're doing what we can. And by the way, we're also focusing on LGBTQ young people, because we know so many of them end up becoming homeless. And if we get to them early, we can keep them with a family, we can keep them healthy.
Thank you. Thank you very much. Thank you, Madam Chairman.
Next, for a second round, we have Senator Capito.
Thank you. Thank you again, Mr. Secretary. We authorized ARPA-H it was funded at $1.5 billion, and you're requesting flat funding for ARPA-H. For those who don't know what that is, it is intended to fund high-risk, high-reward research to find biomedical and health breakthroughs. It's fashioned after DARPA, which is done in the defense arena. And biomedical research has long enjoyed bipartisan support, of which mine is obviously part of that support. I have heard some concerns about either repetitive or deflecting or competitive, maybe, research that could be that is conducted at NIH as opposed to ARPA-H. So ARPA-H reports to you, and NIH is a separate entity. And I would like to know, can you tell me how you plan to make sure that the research activities of ARPA-H and NIH remain distinct? And I mean, I don't think they should be siloed, because